Thank you so much, Ramesh, for your kind introduction from Boehringer Ingelheim. So, very good evening and warm welcome, my dear professional colleagues. So, today we are going to talk about the SGLT2 inhibitor, per se, the empagliflozin. So, with a short introduction of empagliflozin, then I would get into the slides. So, this separate class of the sodium glucose co-transporters inhibitors, SGLT2 inhibitors, are a class of drugs which which have the unique features, unlike the other class of drugs like to start with the bigvanids or the sulfonylureas or the thiazolidinediones or the alpha glucosidase inhibitors or the DPP4 inhibitors or the GLP-1 receptor agonists or the insulin, because you know insulin and the GLP-1 receptor agonists are the injectable the hyperglycemic anti-hyperglycemic drugs. So of late, the semaglutide Rybelsus has come in the form of tablet. Okay, that is the only one exception. So out of all these, see, empagliflozin stands apart. So the reasons are multiple, backed up by the evidence-based medicine. So as of now, we have got three USFD approved gliflozins. We call this class of drugs gliflozins, as we call the DAP4 inhibitors, the gliptins. So the gliflozins, the first gliflozin was dapagliflozin, which got the US FDA approval in 2013, and 2014 early period, the empagliflozin was approved by US FDA, followed by the dapagliflozin, and these are the three available in India, approved by US FDA. So there is one Indian gliflozin, okay, that's not approved by US FDA, and you have got other gliflozins which are not available in India but approved by US FDA, like ertugliflozin, ipragliflozin, and bipragliflozin. There are several gliflozins in the pipeline. The surprising thing is these particular drugs, they started as glucose lowering agents, that is pertaining to the endocrine domain or the diabetic domain or the clinician domain or the physician domain, and later on they started observing the cardiovascular benefits. So especially with regards to the heart failure, and the hospitalization for the heart failure was very much decreased by taking this the group of drugs SGLT2 inhibitors. So thereby the cardiologist started claiming it's our product. Then after seeing the renal benefits, so the nephrologist started saying it is our molecule. So finally, I say it is the molecule of the patients per se. It is not my molecule, it is not any cardiologist molecule, it is not any diabetologist molecule or any nephrologist molecule. See, we all need to pass on the benefits of this particular class of drugs to the patient. The ultimate beneficiary is the patient. So, with regards to the empagliflozin, I would like to highlight some points. So it started as this particular glucose lowering agent, and we observed the control over the blood pressure, 24-hour control, especially the daytime, the morning, the evening, and especially the nocturnal hypertension was very much controlled with this particular empagliflozin. Per se, the systolic than the diastolic was very consistent, at least to a tune of 8 to 12 millimeters of mercury reduction in the systolic blood pressure, and 2 to 4 millimeters of mercury reduction in the diastolic blood pressure. So then this became a very good drug of choice in the cases of nocturnal hypertension, which is very difficult to control. At the same time, it has become the drug of choice along with the standard the treatment for resistant hypertension, because it controls the systolic blood pressure around the clock. So later on, moving to the other benefit is the weight reduction actually. So in my clinical practice, I've seen the reduction with empagliflozin is around some 5 to 6 kilos over a period of 3 to 6 months. So the more the weight, the more the reductions are. Suppose the patient is 100, 120 kilos, the reduction is more. Whereas the patient is 60 or 65, the reduction is less. So it is the patient dependent actually. So whether the patient belongs to now the ideal body weight, or the overweight, or the grade 1, grade 2, or morbid obese, grade 3 obese. So later on, moving on to the benefits. So it has shown the greatest benefits with regards to the reductions in the 3-point MACE, as well as the beautiful reductions in the hospitalization for heart failure and the reductions in the heart failure. So that is the greatest benefit by improving the left ventricular ejection fraction also. So later on, moving to the kidney parameters, it exerted the beneficial effects on the kidney by improving the estimated glomerular filtration rate. So that's a great point in this managing the diabetic kidney disease. And after that, you have a production on the liver actually. So it has become the standard protocol drug of choice in the case of the latest nomenclature is being changed from NAFLD to MAFLD, and NASH to MASH and all. All these terminology is changed actually by the International Society for the Hepatology actually. So there are other benefits like it reduces the serum uric acid level, so that so we generally find the triad actually, the type 2 diabetes mellitus, and the increased the uric acid levels, whether it is just mere hyperuricemia or the clinical gout, or the third component is hypothyroidism. We find all this in one single patient usually. So by reducing the serum uric acid levels, so the patient is going to be benefited a lot. And it has got some other benefits which we are going to talk about. But one thing I would like to say is, see, if at all you want to start a gliflozin and you want to have the benefits, all the benefits which I have mentioned, you need to be like the early bird catches the prey. You need to start this very early in the beginning of the course of type 2 diabetes. The moment the patient is diagnosed with the type 2 diabetes and you say the patient has got, you don't start with simple metformin. So along with metformin, you start an SGLT2 inhibitor, so that the reason is that it's backed up by the evidence-based medicine. Every single word, every single sentence I say is backed up by the evidence-based medicine. There is a term called legacy effect in diabetes. The legacy effect is nothing but the first 10-year course of the diabetes, type 2 diabetes, is very important in deciding or the determining the onset of the macrovascular or the microvascular complications of diabetes actually. So the legacy effect means the first 10 years you need to maintain a stringent blood glucose levels, the fasting plasma glucose and the postprandial plasma glucose and the HbA1c. So it doesn't mean that after that you have to be reluctant. Every minute is important. So first 10 years you maintain the blood sugars very stringently, so that that result is that there is much delay or the much reductions in the incidence of microvascular or macrovascular complications. So with regards to this, we need to start this the empagliflozin or the dapagliflozin early in the disease course, as early as possible. If you start late, like after the patient has diabetes for the last 20, 30 years, and you start an SGLT2 inhibitor like empagliflozin, you have the glucose lowering benefits maximum by the weight reduction. That's it. You don't have the heart protection, you don't have the kidney protection, you don't have the liver protection. So you want to have all these target organs to be protected. You need to start this particular molecule, the empagliflozin or the dapagliflozin, very early in the disease course of type 2 diabetes mellitus, as soon as it is diagnosed or as soon as the patient comes to you. This is the core message. So, like it is indicated for all type 2 diabetes mellitus patients, and it is not a drug of choice for type 1 diabetes mellitus per se. I am telling you, as of now in India there is no indication, whereas in the European Union and in the US, these molecules are being and one more good molecule is sotagliflozin actually. So they are all being used in the type 1 patients also. The result is that the dose of insulin for type 1 diabetes is very much reduced after initiating this particular the SGLT2 class of drugs. But you should be very cautious in type 1 patients. So we are not using it, but theoretical point I am telling you. So there is a term called euglycemic diabetic ketoacidosis, which is very commonly seen in this particular the class of the patients who are using this particular class of agents, especially the type 1 DM patients. So as far as in India, we are using this particular molecule only for type 2 diabetes mellitus, not type 1, not GDM, not other specific types of diabetes. So it's clear, I think, and there are certain contraindications also where you cannot start this molecule. So they are, the first one becomes the recurrent genitourinary tract infections, and the recurrent the fungal infections, the candidiasis or the candidial moniliasis or the candidial vulvovaginitis or candidial velonitis or fasciitis or candidial velanofasciitis. The patient has got repeatedly getting this particular either the bacterial UTIs or the genitourinary tract infections or the fungal infections. It's a contraindication that you should not use this particular molecule. So one time the patient develops, after using this molecule, one time the patient develops UTI or fungal infection, so you can as well stop the drug temporarily. You can stop it and treat that particular either the UTI or the candidiasis, and after that, once the patient recovers, you can put a trial. It again recurs and recurs, so that's a contraindication for this particular SGLT2 inhibitors. And second thing is, when the patient is dehydrated, you cannot put the patient on this SGLT2 inhibitors, because this SGLT2 inhibitors is per se the empagliflozin or the dapagliflozin have got an osmotic diuretic effect. So the patient usually gets dehydrated. So that is another contraindication. So whenever you want to start this molecule, just counsel the patient for 5 minutes that the patient should maintain the genitourinary hygiene to prevent the bacterial infections and the fungal infections. And second thing is, and they ask the patient to get adequately hydrated, at least 3 to 4 liters of water minimum, not exceeding 5 liters, at least 4 liters. So if you exceed 5 liters of fluids, so that again leads to hyponatremia. So, and whenever the patient is in euglycemic DKA, that is nothing but the patient will be running normal blood sugars like 160, 170, 180, but still the urinary ketones are present and the blood ketones are present. So this is the one condition you have to be very cautious about this, and you need to treat the patient like DKA only. You should admit the patient, give him stop all these drugs and give him only the IV fluids and the correct the electrolyte imbalance and give him IV insulin. If not possible, the subcutaneous insulin. Treat him so he'll not get into any complications, or else it's going to endanger the patient's life. So with this small introduction, I'll get into the topic today. See, I am Dr. Sepuri Krishna Mohan. I'm an endocrinologist. I have my own center, Sepuri Diabetes and Endocrine Center at Kurnool, Andhra Pradesh. And once again, a warm welcome to my professional colleagues. And today we are going to talk about the vascular metabolic first aid. It is not the first aid what we give, it is FIR-ST-AID. We'll be getting into the slides slowly and you'll be knowing what the FIR-ST-AID means. In new onset type 2 diabetes mellitus. This is a new topic with the new slides, because I had given hundreds of topics on this particular molecules, the empagliflozin, or the combination empagliflozin and the linagliptin, or the dapagliflozin and all. But today it's going to be an entirely different topic with a different slides and a fresh start, okay, with all the evidence-based medicine. So the slide shows the cardiovascular, renal, and the metabolic the conditions are interrelated, and with high disease burden resulting in cardiovascular death as top cause of death in India. Yes, if you see this, the kidney disease, we have in India more than 115 million people who are suffering from the chronic kidney disease per se. Maybe it's diabetic kidney disease or the otherwise chronic kidney disease. And one more point I just forgot to tell you, that the empagliflozin and the dapagliflozin are the only molecules approved by US FDA to be used in the absence of diabetes in cases of heart failure. So that is the greatest aspect of this, the gliflozins per se. The empagliflozin and the dapagliflozin are the drugs for non-diabetics in case they are suffering from heart failure. See, this is the greatest molecule. See, there are some molecules like GLP-1 receptor agonists actually, so which are approved by the US FDA for weight reduction, like starts with liraglutide. For diabetes, we have got Victoza. Like for non-diabetics, for weight reduction, the same the liraglutide comes in high doses with a brand name, different name, Saxenda. Likewise, semaglutide. We don't have the semaglutide injectables once a week. Liraglutide is once a week. Semaglutide is once a week. And this is available in the US and the other Western parts. So it is called Ozempic as far as the diabetes patients are concerned. And the same molecule is available with a different brand name as far as the weight reduction is concerned. And of late, the a beautiful molecule with a dual action on GLP-1 and the GIP, the receptors, has come, that is tirzepatide, which is not available in India by Eli Lilly. The trade name is Manzaro. It's going to be launched in 2025 in our country. Meanwhile, you get semaglutide injectables also. Right now, you have semaglutide tablets once a day, 3 mg, 7 mg, 14 mg from Novo Nordisk. It is called Rybelsus actually. So, coming to the people suffering from heart failure in India is more than 10 million, which is very alarming. And because once again I tell you, heart failure is an insulin resistant state. Insulin resistant state. So remember, always it is vice versa. The patient suffering from type 2 diabetes, always they have in the background pathology the insulin resistance more than the insulinopenia in the Indian population. So they are liable to get into heart failure at any point of time. So the basic cause, 90% of the cases of heart failure, the underlying cause is the coronary artery disease, what we call the atherosclerotic cardiovascular disease. And most of the remaining patients are the type 2 patients with the atherosclerotic cardiovascular disease, or without that also you find the cases of heart failure because it's a insulin resistant case. And retrospectively, vice versa, you need to check for type 2 diabetes in all the cases of heart failure to rule out the T2DM. And coming to the diabetes, that is the metabolic aspect, you see roughly around the latest data says it is around 101, more than that actually. It's around some 110 million people are suffering from diabetes. And see, cardiovascular death accounts for more than 1 out of every 4 deaths in Indian population. That is the curse actually. See, the main culprit here is the gene that is transmitting this diabetes, type 2 diabetes and hypertension, and the atherosclerotic cardiovascular disease, which includes the coronary artery disease as well as the strokes. These four are inherited by the particular gene. So there is a lot of research is going on the gene therapy that like the gene mutation and all. So they're still in the trial parts. Okay. So getting on to the next one. This slide shows the pathophysiological triad, that is the cardio, renal and the metabolic diseases. They coexist, they amplify each other and progress. So you see the cardiovascular diseases on the top, and the kidney diseases and the metabolic diseases. And over a period of time, that leads to the coexistence, that is the cardio renal metabolic condition increases the risk of developing the another risk factor, and followed by amplification, that is risk and the cause are higher for the patients with the multiple cardio-renal metabolic diseases, and progression. So natural progression of the cardio-renal metabolic conditions that results in the complications over time. So most of the times what we find is the cardiometabolic renal diseases, they overlap. You can see the circles getting overlapped with each other, that is the kidney disease are getting overlapped with the cardiovascular disease and metabolic disease, that is diabetes, as well as the cardiovascular disease is interlinked with the kidney disease and the diabetes, and the diabetes is interlinked with the cardiovascular disease and the renal disease. And you can clearly see this. The 60% of the people with chronic kidney disease have cardiovascular disease, and 30 to 40% of the people with heart failure have the chronic kidney disease. And on the other side, 40% of the people with type 2 diabetes have the CKD, and type 2 diabetes and hypertension and is the cause of more than 80% of the end-stage kidney disease or the end-stage renal disease cases worldwide. And around 16% of the people with heart failure have comorbid type 2 diabetes and CKD. That's what I have told you. They're all interrelated. And 33% of the people with type 2 diabetes have got cardiovascular disease, and 20 to 40% of the people with heart failure have type 2 diabetes. And again, coming to this, the Indian study, the ICMR Indiab 17 study done by this Dr. Mohan and this MDRF Chennai. The projections for the metabolic disease prevalence in India, you can see the bar diagram actually, which shows the incidence of diabetes is around 1 point change millions, And pre-diabetes, the case is even, the number is even more, that is 136 millions, and the dysglycemia is 236 million, and the hypertension is around, the prevalence is 315 millions, and the generalized obesity is 254 million, and the abdominal obesity is 351. Abdominal obesity is the main culprit as far as the Indian scenario is concerned. However, lean the person is got some sort of tummy, that is called classically the Indian tummy. That has got another background, the evidence, that is the thrifty gene hypothesis, and the hypercholesterolemia is around some 213 million. That is the prevalence of dyslipidemia or hyperlipidemia. And high LDL cholesterol, the prevalence is 185 million. This is really alarming actually. So this is purely taken on the Indian patients in the Indian scenario, different parts of the country. Almost every part is covered actually. So down the table, the same the figures are given. It is on top. It is given as a bar diagram. And coming to this slide, the prevalence of type 2 diabetes takes off from 25 to 30 years of age in India. This is again taken from the ICMR India study. So there are four arms actually. See, the urban male and female, rural male and female. The urban male is given in the the straight line with a dot, and the female is given with the dotted line with a central dot. The rural is again the straight line with a triangle in between, and the female dotted red line with a triangle. So this is taken from all parts of India, that is from Tamil Nadu to Chandigarh to Jharkhand to Maharashtra. So the age group, you can certainly you can make it out. The upward rise in the graph is classically is in between the age group of 25 to 34 actually, and it peaks up in the 34 to the 44, and goes up and up in the 45 to 54, and 55 to 64, and respectively. You can see the rise actually. So the start, the takes off, the type 2 diabetes takes off from the age of 25 to 34, and it keeps going up. The curve goes up and up, and the thin fat Indian phenotype, and the premature cardiometabolic risk, newly diagnosed type 2 diabetes, the high dysmetabolic adiposity, and the insulin resistance. On the left hand side, you can see the new onset of type 2 diabetes in India and the UK. The patients in India are totally different from that of UK in the following regards. Like, the patients from India are totally different. They are diagnosed at an younger age, at least 10 years prior to that of the UK population, and they have less generalized obesity, but they have higher adiposity, and they have higher central adiposity, and more of insulin resistance. So whenever you have higher central adiposity, that leads to, in the presence of this diabetes and hypertension and high triglycerides, leads to a metabolic syndrome. Earlier we used to call it syndrome X, now it is metabolic syndrome. Coming to the right hand side, you can see the newly diagnosed type 2 diabetes. You see the bars. See, the age of diagnosis in Indian scenario is by 10 years earlier to that of UK population, and the BMI is less by 4 kilogram per meter square in males, and 6 kilos per meter square in females as far as BMI is concerned. BMI is less when compared to the whites, that is UK whites or the Caucasians. And coming to the mid-arm circumference, it is less by 20%, whereas the waist hip ratio is more by 5%. The SS bar, the TR ratio is more by 20%, and the fat is more by 30%, and the insulin resistance is around 1.5 times more in our Indian population. These are the basic differences between the UK whites and the Indian scenario. So, distinct pathways of the type 2 diabetes development commonly observed among the Indian and the Chinese populations. You can clearly see the Indian population, the Chinese population. See the effects on the pancreas. See, first thing is either the Indian or the Chinese, it is the loss or the decrease in the first phase of insulin response, that is called FI, the PR, loss of the first phase of insulin response. Either it is decreased or it is totally blunted. So, which leads to the increased insulin resistance at the level of liver, at the level of skeletal muscle, and that impacts on this particular the impaired glucose, the impaired fasting glucose on the one hand, the increased impaired fasting glucose, and on the other hand, the increased impaired the IFG and the IGT, put together called the pre-diabetes, and finally to the overt diabetes. And this is a slide showing the good metabolic control is essential in early type 2 diabetes mellitus. That's what I said, the legacy effect, the twin cycle. See, on the left hand you can see the state of excess calorie imbalance, and on the right hand side you can see return to normal calorie imbalance. See, first what happens, the positive calorie balance is influenced by the pre-existing muscle insulin resistance, which leads to the increased liver fat actually on the one hand, and leads to the increased VLDL glyceride, which leads to the subcutaneous fat storage capacity is exceeded, and that results in increased islet triglycerides, and that results in increased insulin response to the ingested glucose at the pancreatic level, and that raises the increases the postprandial glucose levels. And on the other hand, the liver cycle, the resistance to insulin, the suppression of the glucose production, that leads to the increased the plasma glucose and increase the basal insulin secretion, and finally they increase the plasma glucose, resulting into overt type 2 diabetes. Whereas returning to the normal calorie balance is the isocaloric balance after the substantial weight loss, which is influenced by a normal pre-existing muscle insulin resistance, where it is very much low. That leads to, if the insulin resistance is low, you have got normal liver fat at the liver, and that leads to the reduced VLDL glyceride, that leads to subcutaneous fat storage capacity, and that decreases the islet triglyceride and leads to that normal insulin response to ingested glucose at the pancreas, and the normal the postprandial glucose leads to normal plasma glucose. So, moving on to the next slide. So, this is regarding the cardiovascular risk in the newly diagnosed type 2 diabetes patients in India. So, you can clearly see that the conclusions and all. And the risk of subclinical atherosclerosis starts rising in prediabetes, and progression of early the subclinical atherosclerosis study. This is called the PISA study. See, why we are always concerned with the prediabetes, either the impaired fasting glucose or the impaired glucose tolerance, or put together it is called the prediabetes. Why we are basically concerned with prediabetes is, it's very important in that aspect that the incidence of cardiovascular disease and incidence of the diabetic kidney disease is similar to that of the over diabetes. So pre-diabetes has to be taken care. Patients, you must be able to screen the population. You must be able to pick the patients up in the stage of pre-diabetes so as to reduce the incidence of cardiovascular disease and the incidence of kidney disease, because they are very like yeah, equal to that of the pre-diabetes is equal to over diabetes in two segments. One is the cardiovascular disease is same and the kidney disease is same. So taking the coronary, the prevalence of subclinical atherosclerosis by HbA1c in people without type 2 diabetes, and the p-value for trend, it is less than 0.001 across all the vascular territories, that is the p-value of less than 0.001 is statistically very significant. So we take this coronary calcium artery score and then the carotid arteries or the iliac or femoral. And you take any arteries in the body, see the A1C goes up and up. You can see the upward trend in the first bar diagram in the yellow, or the red bar diagram, or the blue bar diagram on the right hand side. Actually, see it goes on increasing, and the all three have got a p-value of less than 0.001. That means they are statistically very significant. So the risk of cardiovascular events start rising before onset of diabetes. This is taken from the NHS, that is Nurses Health Study. That is, it shows the 3.6-fold increase in the risk of myocardial infarction or stroke before the onset of type 2 diabetes mellitus. You can clearly see in this bar diagram that the first one is non-diabetic throughout life, that is the risk is 1%, and the 15 years or more the risk is 2.4%. The risk the risk is 3.19 if in case the 10 to 14.9 years before the diagnosis of diabetes, and the last we are basically concerned is around 10 years before the diagnosis of type 2 diabetes. It is maximum, that is the cardiovascular events are higher with 3.64 fold increase. So we need to be cautious, because it diabetes occurs 10 years prior to that. Caucasians are the whites, the UK people are the US people, Western scenario, and the complications also, the cardiovascular complications are 10 years early in our Indian population. The markers of subclinical heart failure, they start increasing from the pre-diabetes stage. This is called ACE 1950 study. It's nothing but the people who were included in this study were born in the year 1950. That's it. Okay, it's an important landmark study. So the inflammatory markers like CT/NT are the cross-reactive protein, or NT-proBNP, are the left ventricular ejection fraction, etc. And you can see the no diabetes is this the dotted line and the black. The and second is the red is the pre-diabetes mellitus, and the incidence is increased, and the third is diabetes mellitus, where you have much more increased incidence of the subclinical heart failure, even at the pre-diabetes stage. That's what I said. You need to be very cautious at the stage of pre-diabetes itself. You need to give counseling regarding lifestyle modification and therapeutic lifestyle changes, and put the patient on metformin inevitably. So unfortunately, though the American Diabetes Association has been shouting, giving red signals to the doctors who are treating diabetes, that you should counsel the patient, pick the patient up in the stage of IFG or IGT, or put together. It is called pre-diabetes, and counsel them regarding metformin is not important. More than that is the diet, exercise, the weight reduction, and the cessation of smoking and cessation of alcohol. This is called therapeutic lifestyle changes. LSM and plus TLC, and after that metformin. See, mere metformin is not going to do wonders. The basement is all these five what I said: the diet, exercise, weight reduction, cessation of smoking, and cessation of alcohol, if applicable. Plus, metformin is mandatory to prevent all these the cardiovascular complications and the kidney complications in the pre-diabetes stage itself. The greatest advantage of pre-diabetes is if one can adhere to strict lifestyle modification and therapeutic lifestyle changes and put on metformin, it is a reversible condition. See, once it goes to type 2 diabetes, and there is no cure for that. Okay. So this is again the progression of diabetic kidney disease by duration of diabetes. On the left hand side you can see the graph which shows the first stage of the diabetic kidney disease, the hyperinfiltration, followed by the silent diabetes mellitus and the diabetic nephropathy, and the third stage is incipient diabetic nephropathy, and fourth is overt diabetic nephropathy, where in between third and fourth the BP starts shooting up, and the increased incidence of retinopathy you can see, because both are the microvascular diseases. Whenever you find a case of diabetic kidney disease, you need to screen for retinopathy, and whenever you find retinopathy, you should vice versa, you should screen for diabetic kidney disease. It's mandatory that you should do that. And death occurs from cardiovascular disease. Surprisingly, before the patient moves on to ESKD or ESRD, the end-stage renal disease or the end-stage kidney disease, miserably the patient dies of this particular heart attack, that is the coronary artery disease. So few patients land up in dialysis followed by the kidney transplant. Even the results are not good. You take the great leaders of our this thing, Sushma Swaraj and the late Arun Jaitley. Their diabetes and the hypertension and all the comorbidities, both of them underwent kidney transplant. So one in the AIMS and one in the private hospital. They did not survive beyond 1 year. See, that is the pathetic thing. So the classical 5 stages of DKD, that is the reason why we say the microalbuminuria. Microalbuminuria, the earlier we used to call microalbuminuria. The American Diabetes Association has changed its name to USCR, that is urinary albumin creatinine ratio. So see, the microalbuminuria or the USCR, that is this is a sensitive indicator for the future cardiovascular disease. Likewise, another thing is there, that is the erectile dysfunction. Once the patient has got erectile dysfunction, that's an indication that the patient is going to die of. It is a penile attack is interrelated to heart attack. It's a take-home message actually. So the kidney attack or the attack on the penis is equivalent to attack on the heart. That's it. The classical 5 stages of DKD, apart from the EGFR. EGFR, again, it has got different 5 stages. So the stage 1 is called hyperinfiltration, that is increased GFR, possible transient albuminuria. Stage 2, that is silent diabetes nephropathy. The GFR decreases to baseline and transient albuminuria. Stage 3 is incipient diabetes nephropathy. Microalbuminuria becomes persistent. Stage 4, that is overt diabetes nephropathy. The macroalbuminuria develops and the GFR goes down and down. And stage 5 is end-stage renal disease and end-stage kidney disease. That needs for the renal replacement. Prior to that, the patient has to undergo dialysis in the intermittent as an intermittent measure, and unless CV death. See, the pathetic part is the patient suffering from diabetic kidney disease most often will not die from a the kidney disease. They die from a heart disease. That is the take-home message actually. So the Now coming to the CAN, actually the cardiovascular autonomic neuropathy, that is in early type 2 diabetes. CAN is a definite and independent predictor of mortality in type 2 diabetes. Nearly 1 in 5 patients with diabetes may have CAN. So CAN may occur early in the continuum of dysglycemia. 1 in 14 newly diagnosed patients of T2DM have CAN, that is around 7% have got type 2 diabetes newly diagnosed, 7% will have CAN, and 1 in 20 patients develop CAN annually in type 2 diabetes, that is 4.6% to 6% per annum. So in South Asians, although polyneuropathy is less common, prevalence of CAN is as high as Caucasians. And tell you briefly what CAN is. CAN is nothing but you can clinically catch it so easily that you take a resting 12-lead electrocardiogram, you find sinus tachycardia, that is one sign of CAN. You find some sort of arrhythmias, that is, and when you measure the BP, you find a severe orthostatic hypotension, that is a sign of CAN. Either the pre-syncope or syncope. These are all the signs of CAN. CAN is very serious because CAN ends up in sudden cardiac death, SCD. So you need to find out the patients with CAN. You need to screen them, send them to a cardiologist. They need separate counseling, and we need to reduce the heart rate. We need to treat it's a multi-pronged approach to reduce the incidence of CAN, so reducing the incidence of sudden cardiac death. So you need to pick them up early. That is very, very important actually. So the vascular complications in people with newly diagnosed T2DM, this is the landmark study in the diabetes. All the time, the greatest study is still ongoing, the United Kingdom prospective diabetes study. The signs suggest to a vascular complications on the left hand side. On the right hand side, you can see the prevalence. The retinopathy is 21% and the abnormal ECG is 18%. Absent foot pulse are the ischemic feet, that is the peripheral vascular disease or peripheral arterial disease by 14%. Albuminuria, the micro and the macro albuminuria 7%. Impaired reflexes are the decreased vibrations and 7%. Angina pectoris 3%, intermittent claudication 3%, myocardial infarction 2%, and stroke 1%. So now we have come to the title justification part. The what is first aid for new onset diabetes? Well, let us see AID. A stands for adiposity, and I stands for insulin resistance, and D stands for dysglycemia actually. See the adiposity and the insulin resistance and the dysglycemia is called AID. And we see what FIRST is. The failing myocardium is F. The ischemic cardiovascular disease is I. And renal and retinal dysfunction is R. And the systolic BP and the sensory loss is S. And the tachycardia and orthostasis is T. So this is called the first aid, the vasculo-metabolic first aid for new onset of type 2 diabetes mellitus. It's something like a mnemonic that you can easily remember this mnemonic. First aid, so adiposity, insulin resistance, and dysglycemia, the failing myocardium and the ischemic cardiovascular disease, and the renal and retinal dysfunction, and the systolic blood pressure and the sensory loss, and the tachycardia and orthostasis. And this is a bar diagram showing the usage of empagliflozin, the metformin as initial combination in type 2 diabetes, which is more effective in reducing the A1C versus metformin monotherapy. See, HbA1c reduction from the baseline. You can see this bar diagram on the left hand side and the right hand side, and the blue bar is that represents the combination of empagliflozin 5 plus metformin 500 mg BD, whereas the yellow or orange that shows the metformin 500 mg BD alone. You can see the reductions of A1C. The combination therapy has reduced by the A1C by 1.98%, whereas The metformin alone 500 mg BD has reduced A1C by 1.18%, which is statistically significant. The p-value is 1.05. It is not very significant, but it is significant certainly. For point anything, the p-value of anything around 0.05 is statistically significant. So coming on to the right hand side, you find the same the combination, but the metformin is doubled here. So EMPA same 5 milligram with metformin 1000 milligram BD, and the metformin alone 1000 milligram BD. So the combination of EMPA and metformin 1000 milligram BD has resulted in the decrease of A1C by 2.07%, and the metformin 1000 milligram BD has resulted in a significant reduction of the 1.75% of the HbA1c. This is also statistically significant. So that's what I said in the beginning. Instead of, see, now the funda is totally changed. The treatment of type 2 diabetes mellitus, the treatment of hypertension is totally changed. Earlier days we used to, we were taught, and we used to teach in a different manner, that the start low, go slow. That is, start with 250 milligram metformin, increase it to 500 BD, then go to 1000 bedtime, 500 morning, go for 1000 morning, 1000 night. It takes around 6 months to 1 year, and patient disappears in between. So now the funda is that hit early, hit hard, strike early, strike hard. Go with a combination, so that the patient gets all the benefits. Like you start with a combination of the metformin along with this the empagliflozin, the SGLT2 inhibitor. That is the take home message actually, because the A1C reductions, not only the A1C reductions, the blood pressure reductions and the weight reduction, the protection of the heart, liver, kidney, and the reductions in the uric acid level, these are all like you want to materialize them, you need to start the combination early. And again you can see the time in range actually, like you can see, like empagliflozin improves the time in range in uncontrolled type 2 diabetes. The benefit on 24-hour continuous glucose monitoring is observed from day 1 onwards. Okay, and the red line shows the around are more than 180 milligrams per deciliter of glucose, plasma glucose, and the green shows around or more than 70 to less than 180 milligrams per deciliter of blood glucose, and the gray shows around less than 70. Less than 70, always remember, that is the definition of hypoglycemia in ambulatory patients. Okay, so you can see, like the first circles, the placebo, the second is empagliflozin 10 mg, and the last is empagliflozin 25 milligram. The baseline day 1, day 28. It is a very short study actually, but it has got wonderful, tremendous results. You can see that. Okay, the baseline, the placebo has got 52.1 of this the time in range, whereas 47.9 the time above the range, and 10 mg you can clearly see the difference, and 25 you can clearly see, that is the TIR, the time in range is increased and time above the range is decreased. And the day 1 you can clearly see the difference, the time in range and time above the range, the changes you can see respectively on day 1 and day 28. So empagliflozin rapidly clears glucometabolic toxicity and improves beta cell function in people with type 2 diabetes. So the clinical parameters, the baseline on day 2 and day 14. The parameters what we have taken is fasting plasma glucose and C-peptide response, and these are all the hyperglycemic clamps actually. The beta cell function with the insulin sensitivity bar insulin resistance index, and the beta cell glucose sensitivity. So you can see at the baseline, the fasting plasma glucose is 195. Day 2, it got reduced by 25 milligram. See the effect of empagliflozin. Just on day 2, after 24 hours, you can find a reductions in the fasting plasma glucose by 25 milligrams per deciliter, and on day 14 by 38 milligram per deciliter respectively, whereas C peptide at 23 nanogram per ml per hour and increased by 48% on the day 2, increased by 61% on day 14 respectively. The same wise the beta cell dysfunction 88% and increased by 73% and by 112% respectively, and the beta cell glucose sensitivity 0.024 nanograms per ml per milligram per deciliter got improved by 42% on day 2 and by 54% on day 14. So this is again a graph showing the beta cell dependent mechanism facilitates the long term durability of glycemic control with empagliflozin and metformin. So you can see that multiple drugs with multiple colors. Light blue is alpha, the light the orange is metformin, the grey color is thiazolidinedione, and yellow is DPP4, and dark blue is SGLT2 inhibitors. You can clearly see that all the graphs are going up and only 2 are down below are the thiazolidinediones, even proving much better than this particular SGLT2 inhibitors. So the sustainability of blood glucose is more seen with the SGLT2 inhibitors and more so with the thiazolidinedione, that is pioglitazone, a molecule not to be forgotten even in the modern era also. That is the role of pioglitazone. It's my favorite molecule, used judiciously. You select the patient wisely. That's a wonderful drug. That's a wonderful drug. Used injudiciously, the patient lands up. Suppose you put the patient the pioglitazone on a volume overloaded state patient, that results in heart failure immediately or the kidney failure immediately. Selection is very important. See, it is always the clinician's fault to select the patient judiciously as far as the glitazone is concerned. Okay, even till today, the rosiglitazone, which is banned long ago in India, is available in the United States with a black box warning. That is, it should not be used in patients with heart failure. Second thing is, it should not be combined with insulin. So also the only glitazone present in India, forget about the lobeglitazone and all, the gold standard pioglitazone should never be combined with insulin for the fear of getting into a volume overloaded state, precipitating heart failure. So you can see this bar diagram, and we'll move on to so many slides to cover. Empagliflozin lowers the insulin resistance and inflammatory markers. Empagliflozin versus placebo in type 2 diabetes with high insulin resistance. See, on the left hand side you can see the HOMA-IR and the high sensitivity cross reactive protein in the middle and remnant like cholesterol. You can definitely find the empagliflozin compared to the placebo in the red color and the empagliflozin in the blue color. You can see the reduction. The HOMA insulin resistance is reduced by 43%, which is a very beautiful finding, and this is statistically significant. See, when compared to the placebo, high sensitivity cross reactive protein, these are all the cardiovascular the markers actually. The CRP is an inflammatory marker definitely, but high sensitivity CRP is very specific to heart actually. So after using empagliflozin, the HSCRP is decreased by 54%, like even the cholesterol, the remnant like cholesterol got decreased by 52%, that is reductions in 4.19%. So these are all the benefits of empagliflozin, apart from its glucose lowering effect. That's what I told in the introduction. The CV safety studies of SGLT2 agents in type 2 diabetes have proven certain similarities, differences in patients subgroups with atherosclerotic cardiovascular disease. See, these are all the studies, the cardiovascular outcome trials. Of late, the US FDA has taken out the cardiovascular outcome trials, but it has given some criteria that it should have so many patients with heart disease, so many patients, so many 600 patients with kidney disease and all. So the empiric outcome trial is for empagliflozin, the canvas is for the canagliflozin, declare TIMI is for this particular dapagliflozin, and what is CV is for etugliflozin. I told you in the beginning, etugliflozin, the sotagliflozin and the epragliflozin, they are available in the US and the Western scenario, but not in India. And you can see that all are positive with this particular empagliflozin as far as empiric outcome is. And after that, several studies have come with the empagliflozin or even the DAPA also. See, the major adverse CV events, there is 14% risk reduction, the 38 risk reduction with the cardiovascular death, all cause mortality got decreased by 32%, hospitalization for heart failure got reduced by 35%, and the chronic kidney outcomes was 46% reduced. And the canvas, it showed only 18% risk reduction in the major CV events, and no significant CV death and all cause mortality was not seen with any other trials, the given trials. That's what. And you can see the table that it has got some the good effects. Even the canagliflozin also has got like 100 mg, though we have 100 and 300 mg. All the trials were done with 10 milligram of DAPA, 25 milligram of EMPA, and 300 milligram of CANA. You remember. And you can see the reductions. See the out of all, the empagliflozin stands tall on the top. It's something like Mount Everest. That's it. And again, the empiric outcome, the empagliflozin use leads to early risk reduction for the cardiovascular death in patients with the type 2 diabetes and atherosclerotic cardiovascular disease. You can clearly see the overall study population, that is 38% relative risk reduction was seen. When compared to the placebo, you can see the empagliflozin, that is in the left hand side graph, and the right hand side graph, the Asian patient subgroup, 56% relative risk reduction. And in this point, I would like to give you a take home message that the SGLT2 inhibitors are very, very efficacious in the Indian population and the Southeast Asian population and the Asian population when compared to the Caucasians. A better SGLT2 inhibition is seen in our population. Likewise, better DPP4 inhibition is seen in our population when compared to the Caucasian whites. See, they are not very effective. These two classes of drugs, the DPP4 inhibitors and the SGLT2 inhibitors, are definitely distinctly apart as far as our population is concerned, or the Asian population is concerned. They are more efficacious when compared to the whites or the Caucasians. So this is a very good take home message actually. And you can see the empagliflozin reduce the risk of CV death in people with type 2 diabetes and CV disease regardless of baseline estimated GFR or prior hospitalization for heart failure. The empiric outcome, the CV death subgroup analysis. When you take the kidney parameters, empagliflozin reduce the hazard ratio of cardiovascular death by the 30% in people with baseline eGFR of around or more than 90 ml per minute per 1.73 meter square of body surface area, and 51% in people with 60 to 90 ml per minute of eGFR, and 22% in baseline of less than 60 ml per minute of eGFR respectively. And coming to this particular the empagliflozin on the cardiovascular death, the hazard ratio is around they are reduced by 29% in people with prior heart failure, and 40% reductions were seen with then the people without prior heart failure. So these are all the beneficial aspects. That's what I said. It reduces the incidence of heart failure as well as the hospitalization for heart failure, which is a very, very cumbersome and costly and very that is related to the high expenses actually in our scenario. When you go to a corporate hospital, you get admitted in the corporate hospital under the care of the multi-speciality approach. The cardiologist or the physician or the nephrologist or the somebody else and so and so blah blah blah, it goes on. And you need to pay in lakhs. You don't have the insurance system, whereas the US has got and the UK has got NHS, whereas the US has got NIS. We don't have this health insurance systems at all. So you need to pay from your pocket for everything, for the investigations, for the consultation fees, and for the drugs and all. Everything you need to pay, even for the disease or the complications. So you reduce the disease, you reduce the complications, you are going to you have a quality of life apart from the saving money also. Not only related to saving money, maintain a quality of life. QOL is more important than anything. Okay. And again, empagliflozin causes a regression of albuminuria in patients with prior micro and macro albuminuria. That is again taken from empiric outcome. See, left hand side, you see the patients with prior microalbuminuria, they regress to normoalbuminuria. It is around the placebo, you can see the blue, and the red is empagliflozin. The increased likelihood of 43% with empagliflozin coming back to normoalbuminuria. That is regression from microalbuminuria to normoalbuminuria is around 43%. And on the right hand side, the patients with the prior macroalbuminuria, regression to either normo or microalbuminuria, when compared to the placebo, it is 82% more likelihood with empagliflozin. So it's a wonderful drug that has got the multiple, it is called a pleiotropic drug. I call it a pleiotropic drug. Statin is a pleiotropic drug. Metformin is a wonderful pleiotropic drug. And this particular SGLT2 inhibitors, especially the empagliflozin, I don't say dapagliflozin is inferior to empagliflozin, but it has got some superiority over dapagliflozin with regards to A1C reductions, especially when it is combined with the linagliptin. That's what. See, if I want to quote the evidence-based medicine, the EMPA and Lina, the combination reduces the A1C by 1.7%, whereas the DAPA and SITA, they reduce by 1.5% of A1C, and the DAPA and Lina by 1.3% of A1C. Likewise, it's got some edge over that. And I don't say it is an inferior molecule, it's a superior I don't endorse particularly. As a speaker, I'm unbiased because I prescribe empagliflozin in my day-to-day practice for the rich and affordable patients, because still the MNC Boehringer has got at a higher price because it is not off patented, whereas this particular dapagliflozin is not off patented, but okay, they lost in the Supreme Court of India. So in India it has become a cheaper molecule, thereby we can pass on the benefits to each and all the needy patients. So the usage has become more and more after the vildagliptin got off patent, after the sitagliptin got off patent, after the linagliptin got off patent, and some companies have come. The patent rights of empagliflozin are there with the Boehringer until 2025. But some companies, some Indian companies have come. They are marketing in the Indian companies. Okay, it's not our headache. See, the Boehringer has filed all the cases against the people who have launched these combinations, and the cases are pending in the Supreme Court of India. They have given stay orders. Okay, this is not our headache. Of the records, I am telling you. The empagliflozin delays the rapid kidney function decline in type 2 diabetes with cardiovascular disease. The post-hoc analysis of EMPA-REG outcome. You can see the comparison with the placebo. The pooled empagliflozin and the red, they reduced by like it is only 3.4, whereas the placebo is 9.5 in patients with the proportion of patients with a rapid decline in eGFR of more than 3 ml per minute per 1.37 meters square of the body surface area. And you see the same, the 2.2 in the placebo, and reduction by 1.1 in proportion of patients with rapid decline of EGFR of more than 5 ml per minute per 1.37 meters of body surface area. See, the normal is around 10 ml. Okay. So again, the post-hoc analysis of empiric outcome shows empagliflozin delays the time to the kidney failure in type 2 diabetes and cardiovascular disease. You can clearly see that the red line is empagliflozin, and that it shows reductions in the kidney failure in patients who are on empagliflozin when compared to the placebo. The time projected kidney failure defined as an estimated, that's what I tell, estimate the EGFR of around or less than 10 ml per minute of up to 15 years. And SGLT2 inhibitors use results in 58% of lower risk of serious kidney events. This is Scandinavian real world evidence of in people with T2DM initiating SGLT2 inhibitor versus DPP4 inhibitors. See, the DPP4 are given in the blue graph and the SGLT2 in the dotted orange graph. So you can clearly see the Scandinavian belt is nothing but the Norway to the left, and the Sweden in the middle, and the Finland on the right hand side, and the Denmark and the down. This is called the Scandinavian belt. I had been to all 4 countries. Okay, see the number of the subjects included were massive. The subject is so huge that they included around 60,000 patients. It's a great study that is done on the serious kidney events. So which shows on the right hand side, you can clearly see the bar diagram. The empagliflozin has got 2.1 the events per 1000 patient years, whereas the placebo has got 6.2 versus the empagliflozin versus dapagliflozin, which is 2.8, whereas empagliflozin is only 2.1 events per 1000 patient years. This is the difference between the dapagliflozin and empagliflozin. Dapagliflozin is definitely efficacious, backed up by the DAPA-CKD, DAPA-HF, and all has made DAPA a wonderful molecule. But on top of it, a little edge for empagliflozin. That's what, as a clinician, I feel, not as a speaker. Okay. That's what evidence medicine says. See, I practice what I preach and teach, and I teach and preach what I practice. That's it. No difference. So empagliflozin reduces risk of first and recurrent cardiovascular events in patients with type 2 diabetes and atherosclerotic cardiovascular disease, again from empiric. 21% in the risk reduction of myocardial infarction events with empagliflozin versus placebo. You can clearly see the figures here. And SGLT2 inhibitors improve the cardiac autonomic neuropathy outcomes in type 2 diabetes. That is, I said, the pre-syncope and syncope are part of the vasovagal syncope, and is part of cardiovascular autonomic neuropathy. The real world evidence from SCAN study, that is in people with type 2 diabetes and vasovagal syncope, you can clearly see the non-SGLT2 inhibitors, the incidence is very high, whereas the SGLT2 inhibitors, it is very, very low, and the p-value is 0.001, that is statistically very, very significant. So that acts on CAN, that acts on heart attacks, that acts on heart failure, that acts on kidney, that acts on liver, that acts on serum uric acid levels. And one more, the negative aspect of this is the SGLT2 inhibitors, including empagliflozin, they tend to increase LDLC, which is not desirable. See, that's a take-home point, because usually the companies, they highlight the positive points and they mask the negative aspects. But as a speaker, I am totally unbiased. I am not endorsing the Boehringer Ingelheim or AstraZeneca or Johnson & Johnson. I am a speaker for every bloody MNC, all the Indian companies. I am totally unbiased. Again and again, I repeat that with due regards to all my professional colleagues. empagliflozin and the risk of retinopathy in people with T2DM. That is, EMPRA is empagliflozin real world effectiveness. Like you can see the difference between the empagliflozin and the dapagliflozin. That is, the IR is nothing but incidence rates, and the next is the rate difference, that is per 1000 patient years. You can see the difference, and you can clearly see the difference on the right hand side, the difference between the SGLT2 inhibitor, empagliflozin, and the DPP4 inhibitors with regards to the reductions in the risk of retinopathy. So in routine care, the empagliflozin was associated with a similar risk of NPDR and a 23% reduced risk of diabetes retinopathy compared with the DPP4 inhibitors in people with type 2 diabetes mellitus. And additional non-glycemic benefits on top of standard care. 100 patients with type 2 diabetes and CVD using empagliflozin for 3 years have got the following benefits. First thing is the reductions in 9.8% as far as the cardiovascular events are concerned, they are prevented. And it prevents 8.5% of CKD events. It prevents 3.4% of acute kidney injury, acute renal failure, or hyperkalemia are prevented. And the insulin, resistance is reduced, and the additional the SBP goals by 5.1, and the incidence of edema, the new obstructive sleep apnea. Actually, this is the greatest benefit with this particular molecule. OSA is one of the leading causes for the heart attacks. OSA, you cannot ignore OSA. Okay, any patient who snores, they have to undergo the sleep studies and all, the sleep surveillance studies and all. They need to take care of the consult a sleep medicine specialist, the pulmonologist, and they should take a CPAP or BiPAP, whatever that is indicated. And the 3%, 3.4% total additional life years gained. See, these are all the other benefits beyond glycemia of this particular the standard care. So these are all the ADA has given the 2020. Every year ADA releases in the month of December itself. You find in the net, and the diabetes care and the diabetes are the two journals, official journals of diabetes, American Diabetes Association. The diabetes is purely research oriented, and diabetes care is for the clinicians. The first edition, January edition of diabetes care is nothing but the standards of care as far as diabetes is concerned by American Diabetes Association. Every year it releases this, and before even you get the diabetes care January edition, you find in the net around somewhere around in the second week of every December. Like this year 2023 December 15th, we got them on the net. So they say the cardiovascular effects, the metformin and the SGLT2 inhibitors, they got the potential benefit, and the empagliflozin and the canagliflozin, SGLT2, and the heart failure is like metformin is neutral, whereas the progression to DKD is neutral, and SGLT2, the patients are benefited as far as the progression to DKD and HF are seen with only these particular molecules, the SGLT2 group of inhibitors, like SGLT2 inhibitors. So this also says this is from AAS, that is American Association for the Clinical Endocrinologist. That is 2023 consensus update, specifically recommends empagliflozin or canagliflozin as the first line of therapy in T2DM patients with atherosclerotic cardiovascular disease or high risk for atherosclerotic cardiovascular disease patients. the complication-centric algorithms for glycemic control. See, this is based on the complications. This is complication-centric algorithm for glycemic control. There are the international bodies. ACE is American College of Endocrinology. AAC is American Association for the Clinical Endocrinologists. Okay. And now we have come to the last part of it. Okay, summary, take home message. In newly diagnosed type 2 diabetes, the combination of empagliflozin and metformin can be relevant in that is effective glycemic control, low risk of hypoglycemia. This is empagliflozin and metformin combination, and even with a DPP-4 inhibitor, probably makes it a wonderful combination, triple drug combination, which is rose without thorns. It is all the time, all the two drugs or all the three drugs are extra pancreatic in action. So no hypoglycemia and improved time in range, weight loss including reduction of dysfunctional adiposity, improvement in insulin sensitivity and beta cell functioning, sustained release in the blood pressure, especially the nocturnal blood pressure, and the resistant hypertension, and the reduced risk of the MACE, the myocardial infarction, the cardiovascular death in patients with atherosclerotic cardiovascular disease, improvement in heart failure outcomes in broad groups of eligible patients, improvement in kidney outcomes across the spectrum of CKD risk, and optimize the clinical considerations of the risk benefit for each anti-diabetic therapy in principle of the individualized approach for the patient. So I think I've completed today's session. So thank you so much for your patient listening. And if you have any questions, feel free to ask me, or you please type your queries and questions and put it in the chat box so that I can take up the questions. Okay. Thank you. Thank you so much.